I am a very, got it. I am very casual in my speaking style. I am pretty casual in most things. So, um, this discussion is, I'm going to go over some talking points, and then hopefully this will spark some dialogue that we can work off of after we go through these slides. I would like to mention that our group here at UK is working with Epilepsy Foundation to collect some information about perception of COVID vaccines. And there is a survey that is going to go out, and Beth is going to she's going to share the link to this survey in the chat box, and I think we'll send out some information tomorrow more broadly. All right, so thanks for the introduction, Beth. I am going to talk today about self-management and ADA, or American with Disabilities Act, for people with epilepsy. This is a talk that I gave previously in our fellows lecture here. And so I've modified it somewhat for a little bit more of a community discussion. So, if you have questions or comments as we move along, please put them in the chat box. I'm not going to be watching them, but Beth is going to be watching it, and you can also use the hand raise if we want to stop and discuss something. Again, I'm very casual in my speaking style, and I certainly want this to be as beneficial as possible for all of you, because that's why I'm doing it. So my objectives, excuse me, let me see, I'm frozen here. There we go. So my objectives really are for all of you to understand in just basic terms what the Americans with Disabilities Act does and how we can apply it. I want you to be able to identify programs and tools that are available to you, to your family members with epilepsy. And this is not an exhaustive list of programs and tools, but hopefully this can spark some dialogue, and we can learn from each other. I'm learning new stuff every day. I learn all the time from my patients and their families. And then I'd like to leave some time at the end for open discussion, just share ideas, answer questions, anything like that. Okay. So the Americans with Disabilities Act was signed into law 31 years ago, which both seems like a short and long time ago. So as my career as a nurse, the Americans with Disabilities Act has been law. But really, if we're looking, it was signed into law July 26 in 1990 by President George H.W. Bush, which really, 31 years ago is not very long. It is one of America's most comprehensive pieces of civil rights legislation, and it prohibits discrimination and guarantees that people with disabilities have the same opportunities as everyone else to participate in the mainstream of American life. And those things such as employment opportunities, purchasing of goods and services, and participating in state and local government programs and services. In order to be protected by the ADA, one must have a disability, which is defined by the ADA as a physical or mental impairment that substantially limits one or more major life activities, a person who has a history or record of such an impairment, or a person who is perceived by others as having such an impairment. Now, the ADA is not specific on which impairments are covered. And so this takes into consideration a whole lot of subjective and objective data. And so, I write a lot of letters for people who, may meet these requirements or may need some protections. This also covers, issues that are related to employment, transportation, housing, accessibility to public spaces. As we all know that, you know, most restaurants have to be accommodating to people in wheelchairs and things like that. Telecommunications, voting, education, etc. So we will talk a little bit about reasonable accommodations, and then I'm going to talk. We'll just talk about an example. I'll give you an example we can discuss. So reasonable accommodations is any change to the application or hiring process, to the job, to the way the job is done, or the work environment that allows a person with a disability who is qualified for the job to perform the essential functions of that job and enjoy equal employment opportunities. And then I put a link in there, U.S. Equal Employment Opportunity Commission, and there's a lot of information there if you have any questions. And I'm certainly happy to send this link out. So only statutory limitation on an employer's obligation to provide reasonable accommodation is that no such change or modification is required if it would cause undue hardship to the employer. Undue hardship is defined as significant difficulty or expense and focuses on the resources and circumstances of the particular employee in relationship to the cost or difficulty of providing a specific accommodation. So let's talk about an example. A good example might be somebody who has low back pain or who has had a lumbar, which would be low back, spinal fusion surgery. Okay, so they have low back problems, low back pain. And say that they are working a job, they take a job working at a desk, but sitting in the chair that is provided by the employer is uncomfortable or more aggravating to the back pain. So a reasonable accommodation for this individual might be to provide them a stand-up desk. What would be unreasonable is to request certain exercise equipment so that on their breaks and before and after their shifts, they can work out and build up their muscles, right? So although that seems like a really silly example, we can see very clearly that that would be an undue hardship on an employer, you know, to provide special exercise equipment to this employee. So the link that I provided there, it gives guidance on how to request reasonable accommodations and guidelines for employers, but could be addressed on FMLA paperwork as well. And then I took some notes here, you know, something like a small ramp for a wheelchair would not be an undue hardship, but also widening the doors, adding a ramp and a lift could be an undue hardship. So that's another example. So section 504, whoopsie, I'm so sorry. Trying to move my little thingy over here. Section 504 of the Rehabilitation Act. And, you know, for those of us who have young people or who had epilepsy, difficulties caused by epilepsy or other things going through school, you may have heard of the 504 plan. So the 504 plan was developed to ensure that a child who has a disability identified under the law and is attending an elementary or secondary educational institution receives accommodation that will ensure their academic success and access to the learning environment. And this includes rehabilitation or special services, so in-school therapies like occupational therapy, speech therapies, physical therapies, things like this. It's generally preferred over an IEP or an independent educational plan for children who can function well in a regular educational environment. The individual educational plan is required for special education services. And I feel a little intimidated giving this information in front of, you know, Laureen, who is like very well versed on these things. So I'm going to just add here, if you have questions about your child or about things like the 504 plan and the IEP. The Epilepsy Foundation is very well versed in these and can provide more information, as well as Laureen, who does a lot of work with Epilepsy Foundation too. The Epilepsy Foundation will provide a representative to attend these meetings as well if that is needed. And we've seen some situations where it really was, you know, to make sure that kids got what they needed in school. Disability resources. I've got a link here, and this is a link for legal disability laws and services for individuals with epilepsy and advocates. Topics here include discrimination in education and employment, as well as the ADA and public accommodations. So there's a lot of information that you can glean from this link as well. So I would also like to mention the Kentucky Protection and Advocacy Group. This is an independent state agency that exists to protect and promote the rights of Kentuckians with disabilities. They do this through information and referral, technical assistance, education and training, and legal advocacy. So if someone contacts this agency, there's usually somebody who will gather some information and then assign them a representative. So it usually takes 2-3 days to get for them to call back, but they can get your information and they can assign you an attorney to help you through some of these protection laws. And if you need representation, they can help you that way too. Okay, so we're going to shift to self-management. I'm going to take a drink real quick here. Any questions so far? Beth, do you have any chat questions?
I do not as of yet.
Okay. All right, so self-management involves 3 areas. Treatment management, so those are things like taking medicine, keeping medical appointments, communicating effectively with your healthcare providers. And I've also placed in here barriers, because when I gave this talk originally to our physicians, I wanted to discuss things that maybe they didn't hear a whole lot about. You know, as a nurse, I have the ability to get different types of information than our physicians do. But some of the barriers to treatment management are memory, education and ability to understand, insurance, finances, transportation, internet capability, comprehension of directions, side effects of medications and seizures. And then there are some cultural considerations. So, you know, for example, we have a relatively decent size refugee population that we see here at UK. And we have to consider a lot of the things that they, you know, their backgrounds and how they approach illness and treatments and things like that. Seizure management. So recognizing and avoiding seizure triggers and keeping track of seizures. So barriers here are lack of insight, altered mental state. So if somebody is postictal or they don't remember that they have seizures, it's really hard to keep track of them. Seizures can affect memory and then also the environment. And then lifestyle management. So getting enough sleep, stress management, healthy lifestyles. So barriers to this is just, I mean, really, we all have stress. So life in general gives us stress sometimes. Support at home could be lacking, you know, so that makes a difference for people. And then comorbidities or other health problems. So I'll talk a little bit about programs and tools. And before I talk about this, I'm going to just tell you that one of these programs is currently available, while the others are not. However, the Epilepsy Foundation of Kentuckiana and myself are working to try to get these to this area so we can provide these treatments. But I'm going to run through them just really briefly so that if you see this come out in one of the Epilepsy Foundation e-blasts, that you are at least aware that this program is, these programs have been used and tested and beneficial. So managing epilepsy well, or the MU network, is a really great place to go to find available resources. They provide evidence-based epilepsy self-management programs, and we'll talk briefly about these: Hopscotch, PACES, Pearls, Project Uplift, and Time. So Hopscotch is a program that I have been trained to do. And then we did have a social worker with the Epilepsy Foundation who was also trained, but she left, and I don't know what's available in Louisville or other areas. But hopefully we'll get new social worker for Epilepsy Foundation on board, and we can provide this to more people. But Hopscotch is a self-management program. It's designed to help people with epilepsy find ways to manage and cope with their memory problems. And that's what we're focusing on in order to lead happier, more productive life. So it is a structured program involving 8, it says 45 to 60 minutes each, 8 visits. And these can all be done via telephone or telehealth. And I think that the telemedicine works, or the telehealth or Zoom or whatever platform you want to use. I mean, generally speaking, we're all pretty flexible with what's available. That works very well. And so the components include education, self-awareness training, problem-solving therapy, and memory strategies. So it's a little bit like mindfulness, and also incorporating some of the memory strategies to assist with, retaining these things. And hopefully that helps with our 3 self-management tools: treatment management, seizure management, and lifestyle management. Okay. PACES in epilepsy. This is a program also for self-management. This is also another 8 visit. We can do this over phone, over telemedicine. And this is a focus for psychosocial management. So it looks at, I think this is the one that looks at depression. There are a couple that really focus in on depression, but they cover topics like epilepsy and medical issues, dealing with stress, and the blues is what they're calling it, compensating for cognitive challenges, things like that. Then Project Uplift, and I have contacted the folks who are doing these in Ohio. And they're the ones that are rolling this out, and so I'm hoping that I can provide these. And these are group. I think all of them are groups. The PACES might be an individual therapy, but Project Uplift is also something that addresses depression or mood issues in people with epilepsy. And so it's kind of a mindfulness, cognitive behavioral modality. Time, self-management for people with epilepsy and a history of negative health events. So this is for somebody who may have other medical problems. And this is, hopefully all of these are really to improve the outcomes of epilepsy, just improve quality of life for people. And then SMART is targeted self-management for epilepsy and mental illness. So, mental illness is not an uncommon thing. It's certainly not uncommon in people with epilepsy. So, we have to address epilepsy, and we also have to address, things like depression, anxiety, and other mental illness. because those things can make the epilepsy worse, and the epilepsy can make those worse, and it's a kind of a vicious cycle. Medication issues are the number one call I get, or the calls to the clinic. And the questions are, we get questions about certain medications before people start it. What are the side effects, or I'm afraid of these side effects, or is it going to, is it going to cause a problem with, this other medicine that I take? Sometimes missed medications, or doubled up medications, or somebody threw up their medication. Reporting adverse effects or perceived adverse effects. And I get a lot of calls, and it's okay, because my job is to talk people through it and reassure them about their medicine. But a lot of times I get calls about side effects that definitely, or symptoms that are definitely not a side effect of medication. Perhaps someone started a new medication and then they developed a sinus infection. There is no direct correlation, but sometimes we just have to talk through that and provide reassurance. One of the biggest calls, though, is when people cannot get their medication. Okay, and so there are a lot of reasons this happens. And if you have ever called the pharmacy or gotten a text message from the pharmacy or call and they say that they cannot fill your medication, we need to know why. Okay, because there are a lot of reasons. Now, you can call the clinic and you can say, I can't get my medicine, and leave it at that. But we will spend a lot of time trying to figure this out. If you can find out why, sometimes it's just as silly as, they don't have that milligram tablet. And I can give a personal experience. I take a medication, or I took a medication that was 50 milligram tablets, one a day. Well, I got a call from the pharmacy when I tried to fill it, and they said that they could not fill my medicine because they did not have it. And so I said, well, do you have the 25 milligram tablets? And they said, oh, yeah, I guess we could do that and just do 2 a day. And I said, well, let's do that. So it's good to know why they're not able to fill your medicine. Sometimes it's not covered by insurance, but that's not always a one simple answer either. So it could be not covered by insurance because, one, they don't have your accurate insurance. Maybe you change plans. Well, your pharmacy may not have that information. Or if you have a primary and a secondary insurance, sometimes they'll run it through the primary, but not the secondary. And this gets really confusing. And I've been doing this for a long time. It's very confusing to me. And so I can only imagine how it is if you have something that's also like interrupting your thought processes. Sometimes it can be really challenging. Sometimes it's too early. So let's say you take a medication that's a scheduled medication. Well, they only give you like this very short window to fill it, which is certainly a pain. Okay, so let's say you only have a 3-day window from your medicine runs out, or you've called the day before your medicine runs out, and then you find out you can't get it. Well, this is super frustrating for everyone, right? But sometimes it's too early. So if you try to call a week ahead to get something like Vimpat, then they're not going to fill it because it's too early, but they might not share that information with you. Okay. Sometimes it needs a prior authorization, and a prior authorization is a really sneaky way for insurance companies to not pay for your medicine. So I spent a lot of time arguing with insurance companies to prove that our patients need the medication that the provider wrote the script for. The idea is they want you to take the old drugs, the older, cheaper drugs, rather than the newer, expensive drugs. But as probably most of you know, those older, cheaper drugs, although they might do pretty well controlling seizures, they can give you some really nasty side effects. So this is why we use a lot of the newer, more expensive drugs, because a lot of them are formulations of the older drugs that we've pulled out some of the yucky stuff, and we do have some newer drugs that work a little bit differently. Sometimes, and this is difficult, and it usually happens in January, People get they have a $0 copay or a $10 copay for their drug, all through the year. And then January comes and they're hit with a bill for like $800. Well, is it that the insurance isn't covering it, or do you have a really high deductible? Sometimes people have insurances that have like they have to reach a $1,500 deductible. That's unreasonable for any of us, really. I mean, nobody can pay that much money for one medicine. But those are questions that you need to ask. And sometimes the manufacturers of the medication can help with this. So if you have a high deductible or a very high copay, you might get on the website of the manufacturer of the drug and you might be able to find some coupons that way. You can also talk to, some folks at your clinic and maybe they can help you. So sometimes you need a prior authorization for brand for the drug or for the quantity limit. If you take lamotrigine or Lamictal, 200 milligrams twice a day, your insurance wants you to take a 200 milligram tablet twice a day. They don't want you to take 8 25 milligram tablets twice a day because they're actually paying per pill. So this is super confusing. Pharmacy doesn't have it. So either they don't have it in stock or they cannot get it. Two different things. Good to know. If you are having a pharmacy that consistently does not have your medicine, even though you've been getting it there and every month it's a problem for them to get it, you probably need to consider switching pharmacies. Switching pharmacies is usually as easy as picking the pharmacy you want, calling them, saying, I would like to transfer all my scripts, and then they take care of everything else. Okay. Sometimes it's coverage of issues with a provider, like maybe there's their paperwork's not done or whatever. That's something, of course, the clinic needs to deal with, and sometimes you can just get another provider to write for it for a month. And then, sometimes people can literally not travel to the pharmacy. And, now there are a lot of mail order pharmacies that can help with that. There are a lot of programs that pharmacies provide now where they can do like a monthly fill for all your medicines and get you on schedule. Now, if your pharmacy is unable to do this, I would contact your insurance company and talk to them and say, listen, it's really hard for me to go to the pharmacy 4 times a month for the medication that I've been taking for, years. So I'd really like to be able to get it on a schedule so I can pick them up. And sometimes they can help you with that. And I recommend it to try that if you are having problems. So talking about self-management with medication. So ideas, and these are all very simple things. But sometimes it just takes a reminder. So utilize these pharmacy services like auto refill, delivery, text notifications, use a pill box. And I have several patients that I work with that call it the grandpa. And I don't know where that came from, but I think it's funny. And, to be quite honest, I have a grandpa too. So, and I don't take that much medicine. So, but it reminds me that I took it or didn't take it. Use alarms. So set alarms on your phone. Most of us have a smartphone or, some way that we can set an alarm. Use it. That's a really great tool. Use it and be consistent about taking it when your alarm goes off, which means you might have to have a dose on your person. So calendar reminders to take medicines and to call for refills. So if you pick up your last refill on your medication, it might be, go ahead and call your clinic and say, I'm going to need refills on this medicine, or let your pharmacy know. And here's something that you should probably always follow up on. Sometimes pharmacies send requests for refills. Now, maybe they do and maybe they don't. Sometimes those requests go to a fax machine that maybe doesn't even exist or isn't manned anymore. So if you're relying solely on your pharmacy to take care of this and you're having problems, then take it upon yourself to make a call to the clinic every time you need those refills, okay? I mean, refills like refill on the script. Obviously, if you have several refills on your bottle, then you're good for a while. Develop a relationship with a good pharmacist who can help you. So this is, I think, really important for people who have a lot of confusion, their meds change and all this stuff. There are benefits to using a small family pharmacy, but there are also benefits to using a big box pharmacy like Walmart or Walgreens or something. So, you know, these small pharmacies can sometimes do a lot of creative things to help you. These bigger pharmacies are open 20, you know, they might be open 24/7, and that might be what you need. So if you have a pharmacy that's not working for you, then you should consider another pharmacy. Ask questions. When somebody says you have a problem, you're having a problem filling the medicine, ask them, you know, and if you still have questions or you're having problems, call your insurance company. Sometimes they can be really helpful. Some of them provide patient assistance services. Like I said, they can do like auto refill, and they can get you on a schedule. Sometimes they'll do blister packs, so you have your doses all in like little packs per, you know, it'll come on a roll, and then you can just tear off your morning dose. So, you know, that is available for some people. Transportation is huge. Okay, so I'll talk about what's available. This is tough, you know. In Lexington, we have Lextran. This covers Fayette County, and we do have it's called paratransport. It's called Wheels, and they will. This is part of Lextran, but if you are eligible for this service, they will come to your house and pick you up. And you can use this for grocery shopping. You can use it for doctor's appointments. You just have to schedule them in advance, and they'll basically take you and pick you up anywhere, as long as it's not an emergency. Obviously, you shouldn't schedule, you know, ask them to come pick you up to take you to the emergency room. That would be an inappropriate use of that service. But if you believe that you would benefit from this service and you do live in Fayette County, you know, you contact them and you get paperwork for the clinic and give it to your provider, and they can confirm that you need this service. And this is for people who, for whatever reason, it would be unwise for them to use the regular bus service. Like, it would be dangerous for them to cross several streets, you know, because if they had a seizure, they could be hit by a car, things like this. And it's usually pretty easy to convince, to be convincing for this service for our patients. Uber or Lyft or taxi, you know, but this costs a lot of money. So that can get really pricey. Medicaid transportation. So this is a service offered through independent brokers through the state of Kentucky. So every county in Kentucky uses a different company. So if you live in Rowan County, you have a medical transport service that you can use if you have Medicaid. So what it requires, and there's a link there that you can take a look at. But if you Google Human Service Transportation Delivery Program, you'll get a list of all the services provided in Kentucky per county. So you can contact them to set this up, and they'll get some information from you that you need, basically like a 3-day heads up. So if you know that you have a doctor's appointment in 4 weeks, you can go ahead and call them when you get that appointment, ask them, you know, tell them that you need a trip to the doctor on this day, yada, yada, yada. They'll tell you what to do. So referrals to this actually come from the local primary care provider, and they'll walk you through this if you call. But the local primary care provider is basically stating that they cannot provide this specialty care in their clinic, and so they believe that it is medically necessary to travel to Lexington to go to the epilepsy clinic, or to Louisville to go to the epilepsy clinic. And then we'll talk about driver's license medical review board briefly. So for all of us who go into the DMV, to get a driver's license, they will ask you, you know, have you had a seizure or a blackout in the last 6 months? Is it 6 months or 3 months? Now I'm second guessing myself, maybe 3 months. But anyway, they're going to ask this question, and you know, yes or no. If you ever answer that yes, then they're going to require that you get this paperwork filled out by your provider saying that you are, you know, safe to drive a vehicle. And so it is a form that you need to get as the patient. The first part of the form has got to be filled out, and basically that's giving consent for the your practitioner to fill this paperwork out and submit it to a third party, because we really can't release that information unless you say it's okay, and we have to have that in writing. So you fill out that first part and you bring it. And one of the questions they're going to want to know, when was your last seizure? Now, this always, I mean, driving is a huge issue. It is the number one complaint of people who have epilepsy, is driving restrictions. And I spent a lot of time talking to people about it. Super frustrating. And I've got all kinds of stories that I could share, but I will not go there. I think everybody on this call probably knows. Anyway, if you have questions about this, talk to your doctor, talk to your nurse, or talk to some folks at Epilepsy Foundation. You don't have to be a UK patient for me to answer questions for you. So you can always contact the Epilepsy Foundation too, and they can put you in touch with me and I can answer questions for you. Okay, so I do get calls about technical issues, and I'll just briefly go over this: appointment and clinic issues. So if anybody has a device, I would recommend that they always keep their device card with them. And that would be for a VNS, an RNS, or NeuroPace, or DBS, or any other, I mean, any implant. You should have your implant card, and you should keep it in your wallet or your purse, or take a picture of it on your phone and save it to favorite, so you always have that information. Side effects with these things often require in-person visits, but you know, anytime you're at some small ER, if you ever have to go there, they're gonna fret about your VNS or your DBS, and they're gonna want to know information about it before they do any sort of scanning. It makes it a whole lot easier and a lot more efficient if you actually have your card on you. Appointment and clinic issues. So we know that telehealth has opened a lot of options for people who can access that, and this is great for people who have transportation issues. As long as you have internet, you can connect. We know there are barriers through the call center, internet accessibility, and some comprehension issues. I think it's always important to have a direct point of contact if you can. Okay, so self-management, increase in seizures. So how do we know if we have an increase in seizures? It's really hard if you don't have some objective data. And for people that don't remember or unaware that they have seizures, this is really tough. Sometimes you have to rely on family members, and you just do the best you can. But keeping a seizure diary is so important. Jot down, you know, you don't even have to have anything special, a piece of paper that you can kind of keep handy and scribble, so that when you come to your doctor's appointments, you can bring it. But if you're looking over, you know, in May you had 8 seizures, in June you had 4 seizures, in July you had 8 seizures. You know, we can detect these patterns. We can kind of see where, you know, we increase this medicine, we drop this one, and we can look at these patterns and see that, you know, maybe some people have a cluster of seizures around certain parts of the month, or they're having them more during in the morning or at night. These things, you know, we may be able to tailor their treatment to this information, and we rely so heavily on the patient and their families to provide this information for us. My Seizure Diary is an online tool that you can use, and then Seizure Tracker, also an app which is free, I believe is still free, and you can put that on your phone, and that will video if you want to do that. I always tell people that if they're having, you know, if their family member is having something concerning, take a video of it if you can. And review videos and try to tell people if we should be concerned or not concerned, or whatever. All right. Seizure action plan. A lot of these are done for kids going to school, but I would recommend it for anybody, really. I think these are great for people who are going to take flights. This is something that you could hand to the flight attendant as you walk in and say, I have epilepsy. Sometimes that means I have seizures, but I would like to give this to you. So in case I have a seizure, you kind of know what you want me to do, or whatever. Because they'll thank you for that. They'll be glad to have that heads up, because although they don't want you to have a seizure in flight, they also don't want to have to panic, and that's what happens if somebody has an event on a flight and there's no one there to really explain what's going on. That can be really scary for everybody. It's a great tool for employers. It's a great tool for teachers, social workers, daycares, and things like that. So this is available. It's a fillable PDF online, or you can just print it and fill it out, which is usually how I do it. I'm going to mention the Embrace 2. It's a smart monitor, and this thing's pretty cool. It is helpful for people who have tonic-clonic seizures. And I say that because what it does is it picks up sustained muscle tension or jerking. And so let's say if somebody has tonic-clonic seizures and they have sustained jerking of their arm, which the watch is on for maybe 7 seconds, it's going to send a signal to, maybe their mom or their husband. And they can have somebody check on them. So that offers a peace of mind for a lot of people. The Epilepsy Foundation can provide these. They have a grant that covers these, so they can provide them to patients at no cost. The patient or family is responsible, though, for the cost of the service, which I do not know how much it is. I know that my guess is everything I pay for is like $30 a year. That would be my best guess, but I don't know. So that would be something you'd want to look at. And then all they need is this prescription from your doctor. And I send it, usually I just take a picture of it and I send it to Beth, and she takes care of it. For financial and legal issues, I generally defer to Epilepsy Foundation when people are struggling with this. This is not my area of expertise. But many employers or institutions have an ADA department within HR. So if you work for a company and they have a human resources department, there's probably somebody in there that handles disability stuff. Same with colleges and things like that. And then also point them to Kentucky Protection and Advocacy. For self-care, we hear a lot about self-care and wellness. It's so important. And I'm going to tell you, it's so important right now. Things are so stressful. They were already stressful. We're going on, 18 months or so of some really high stress stuff with all this COVID and everything. But it is important, and I have to remind myself this frequently, it is important to take care of ourselves. Okay. So, we can't be good all the time, but we just have to do the best we can. And those things are, things like having a healthy diet. If you're struggling with energy levels, if you're struggling with obesity or something like that, we could always refer you to a nutritionist or a dietitian. Good sleep patterns. So, having a regulated sleep-wake cycle is very helpful for people, particularly with epilepsy, particularly with certain types of epilepsy. Some people are very, very sensitive to sleep deprivation. Having a routine is really great. Mental health management, and I cannot stress this enough, we all need some help in that area sometimes. And I always, I tell people that I get, the reason I'm not crazy is because I go to therapy, and that might be true. I always joke that I'm crazy and that's why I go, but in truth, it's because I go to therapy that I'm not crazy. Social connections are so important. Get them, however, find different ways to connect with people, whether it is a Zoom call with your family routinely, or some friends. Maybe they moved out of town, and there are many ways that we can connect with people. We have a monthly support group that anybody can attend. We also have and I'll talk about a few of these things, but we just are having our inaugural book club for people affected by epilepsy, and we'd welcome anybody who would be interested in attending. And that goes for caregivers, for people with epilepsy, for their family members. And it's just a way to connect and have fun. So I think social connections are really, really important. And that is one thing that often people with epilepsy are lacking, is just social interaction. But ultimately, find something that makes you feel good. So exercise, yoga, mindfulness, or meditation. Get outside, even if that means just sit in your backyard for 20 minutes a day. That is really good for your health. And then find other ways other healthy ways to manage your stress. Community connections. I just added a little bit what I had just, discussed. Join a support group. Epilepsy Foundation of Kentuckiana has support groups. They have lots of ways that people can connect. They have youth groups. And then our group that I am in with Laureen, is the Central Kentucky Epilepsy Support Network. There's certainly a lot of overlap because Epilepsy Foundation folks do participate in our events, and we're so grateful to have them. But, events that you may consider attending when we can ever meet in person, like we have fundraising events. So we have the gala, we have the walks, dinners, picnic with the pops. We've done that before. We've done Lexington Legend games, and I so miss that. We do educational sessions. Again, we have a book club that we're starting, and if anybody's interested in joining that, please go to our Central Kentucky Epilepsy Support Network Facebook page, or certainly message me or Beth. We can help with mentoring, and we do educational events for special interest groups. So I'm always willing to take topics of interest from people. And when we have kind of a collection of people who are interested in certain topics, we put together a little session. I mean, even if there are 3 or 4 people joining, sometimes those are the best because it gives people really a good chance to ask questions and discuss. All right. And with that, I'm going to wrap up, and I'm going to open this up to discussion. I'm happy to share anything that I have experience in, or answer any questions that you might have. And also, if people want to share stories, that's fine too.
Okay, so if you would like to ask a question, please feel free to unmute yourself if you don't want to be on camera. You really do not need to do that if you're uncomfortable. I do have one question for you, Rachel, and I feel like I know the answer, but at the same time, you have been trained. So can you explain why hopscotch is not available for older children or the adolescent?
Well, I will tell you what I think, but I don't know that this is the answer. And I'm being recorded, so
Yeah.
don't take me. My guess is that when they rolled it out, they used some sort of data collection tool that was specific for adults. And I suspect that with adolescents and younger people, that they probably would need to modify some of the sessions slightly, maybe to target like a slightly less engaged audience, perhaps shorter sessions. But I don't really know the answer to that. So I'm sorry.
Yeah,
I'd be
I
happy.
figured it was just because that was the way the program was designed.
I would say it started with adults, and hopefully they are working on something for adolescents. I mean, my guess is we're stretched so thin that that's probably not in the works at this moment. But I could certainly ask that question if somebody specifically wants to know that. You can send me their info.
And I have just provided my email address in the chat box. So if you have any questions after the session that you would like me to ask Rachel, or you would like any of the links provided in Rachel's session, or any of the links that I provided in the chat box, please reach out to me. I'm more than happy to send those to you. In the chat box, while you were talking, Rachel, I added in the seizure action planning form link. If you would like that, go there. And that's the form that Rachel showed you a little bit ago. And then the plans for the monitoring of the Embrace 2 seizure monitor watch start at $9.90 a month. So while that might seem high, it also, if the watch is provided to you by the Epilepsy Foundation, and we do have somewhat limited quality for adults, we get 10 a year through the Kentucky Kernels. So that's something to keep in mind. If it's something you can afford, you may want to think about that, but we are here to provide those for people in need.
We could also probably, for some people in need, could probably write a letter of medical necessity to insurance companies as well. I think I must have taken all 10 of yours.
Well, no,
sorry.
You didn't. You did not at all, because we have a new grant for this year. So
Okay.
I still have some left to go, and we had a backlog from last year where they sent them to our office. So no, please keep them coming. If I run out, I'll let you know. But I do feel like I did get a call from a lady yesterday who said that the insurance was going to cover it. And I believe assistive technology is something that it could be covered under. So check it out, but just, I will take the scripts while I get them. And then when I run out, they'll have to wait till next year for us. But luckily we do have graders. And then for children, the COSAIR Charities provides generous funds for us to just pretty much get them as needed. So
terrific.
Any other questions? Well, Rachel, thank you so much for doing this for us tonight. I learned a lot. I hope that those of you that participated learned a lot as well. Oh, wait, we got a message. Oh, excellent presentation, Rachel. Thanks for the information. And I will concur with that. I so appreciate you giving up your time. I know you are busy working at the hospital, considering the staff shortages and whatnot with COVID. Thank you. Thank you. And please reach out to us if you need us. My email address again is in the chat box. It's bstivers@efky.org. I can send you Rachel's contact information if you would like. I also included the Central Kentucky Epilepsy Support Network Facebook page in the chat box. And if anybody needs me to send that out after the fact, I am happy to do so. So thank you so much for joining us. Rachel, do you have any last words?
No, but I would urge everyone to please take the survey for the COVID vaccine.
Yeah, and that's at the very top of the chat box. We will be sending that out. If you have yet to get your COVID vaccine, discuss that with your neurologist, please, and see if it's something that you should do, just because there is some concern that if you were to get COVID, that it could make seizure activity worse. So just talk it over with your doctor, figure out the best steps for you, and please trust your medical practitioner's advice. They have your best interests at heart. And other than that, thank you, Rachel, and I will close us out. And again, email me if you have any questions, and we'll see you guys soon.
Okay.
All right.
Thanks, everybody.
Bye, everybody.
Okay.